Good evening all. First of all, I'll thank Sushil Chauhan, my dearest friend and Physician Forum of India, for giving me this opportunity to moderate this session. We have heard Professor Raju Vaishya earlier also on many occasions. He is a professor and senior consultant orthopedics and joint replacement surgeon in the Trust Apollo Hospital, New Delhi. He had his initial education of MBBS and MS Orthopaedics from Gwalior Medical College and MCH Ortho from Liverpool University, England. Then he did his FRCS from London, from Royal College of Surgeons, London, and FSCS USA from American College of Surgeons. He has many achievements and he has world record. He is a world record holder listed in Limca and India Book of Records for 4 times for doing bilateral total knee replacement in the oldest person and in a couple at the age of 93 and 86 years. He has featured in the Asia Book of Records twice for setting a world record, for setting a record for writing maximum articles on the pandemic COVID-19 in a short time of 3 months and 20 days by publishing 40 articles and by publishing maximum number of 106 papers in 2020. He has more than 700 publications in international and national orthopedic journals, book chapters, books and blogs based on his clinical work and research. He is a pioneer in using 3D printing, patient-specific instruments for total knee replacement and cartilage transplantation in India. He is a recipient of several distinguished awards like Dr. B.C. Roy Award and Gold Medal of MPIMA, Siemens KPO Award, Distinguished Researcher Award of AHERF. He is also an editor of 8 medical journals. He is chairman of Basic Science and Research Committee and ex-chairman IT and Web Resource Committee and member of Ethical Committee of Indian Orthopaedics Association. His biography is there, it has been published in Wikipedia both in English and Hindi, and he has special interest in hip and knee surgery, arthroplasty and arthroscopy, 3D printing, joint preservation techniques, research and publications. So we'll hear him shortly. Thank you.
Thank you, Dr. Wadhwa. Today I have the pleasure of, actually I am feeling proud that I've got 3rd generation of doctor from my family with me, Dr. Abhishek, who is my elder son. My father was the first doctor in my family, and after that we have now more than 35 people in the family. So instead of giving a talk on a particular topic, I thought let me share a few interesting cases with you, and the first 2 cases will be presented by Dr. Abhishek, and then I will present the remaining 2. Dr. Abhishek.
Good evening everyone. Thank you so much for the warm welcome. I am Dr. Abhishek and I will be talking on 2 interesting cases. So, to discuss first, this was a 54-year-old gentleman. He was quite obese, who came with after an accident. He was sitting in a car and it hit a cow, and he sustained a very bad injury to the hip. So these are the X-rays. We can see that there is a very bad pelviacetabular fracture of the left side. So if we did a CT and it looks something like this. So it was a very complex sort of injury, and we were wondering that what can be the management for this patient, because we had multiple problems. First of all, he was obese. Secondly, he had a very complex sort of injury which included the acetabulum as well as the pelvis. And we know that after a very major accident, there is a cytokine storm and all those problems are also there. So we took this liberty to take 3D printing into play, as we are doing 3D printing. So what we do is we take the CT images, DICOM images, and we have a software where we can see these images and we can play around with these images. We can exactly plan our surgery on these softwares, and we can exactly know what sort of implant we want to use, what is the size of the implant we want to use, and how the surgery will look even before the surgery has been performed. So this was a 3D printed model which we printed even before the surgery was done, as the patient was being optimized. So we knew exactly how the bone is looking, because pelvis is a complex structure, and once we have this model in hand, it is very easy to plan the surgery. We planned for doing a plating to the pelvis, so we could actually mold the plates before the surgery was done, so that we don't waste our time inside the surgery hall, and the plates are already autoclaved and molded for us. And also we wanted to see if we could do a hip replacement, because he was 54 years old, and if we did a fixation, then there were chances of arthritis in the hip. So we thought, why not go for a definitive solution which will give him a faster rehabilitation and good result. So we could actually see the size of the hip which we wanted to put in, and if it fitted nicely, we could template it and we could order the implants according to the patient's specific needs. So this was the X-ray which looked like this in the post-op period, and the patient was doing fine. He was discharged after 5 days. And he came after 1 year to us. This was the X-ray. He was walking nicely without any problem. He could sit, and this was his functional outcome. So 3D printing is a very good tool, and it can be used to reduce the time inside the OT, to reduce the complications, the blood loss, and the anesthesia time as well. So the 3D printer looks something like this, where we can see this is the plate where the model is built. So we use the additive manufacturing technique. There are two types of techniques: additive and subtractive. Additive is that the material builds the model on this platform, and subtractive is that there is a block and it subtracts, it takes away the material to build the model. So it is quite useful in orthopedics to understand the anatomy, plan the surgery, and also to order customized implants. So next case is a wrist case. So this was a 34-year-old man who had an accident. He was driving a two-wheeler and he had a fall, and he sustained an injury to his left wrist. He went to a local practitioner, and this was the initial X-ray. So this X-ray looks quite benign. There looks to be a small styloid fracture, and if it is not a trained surgeon, anyone can think that it's a very simple styloid fracture, and that physician just initially thought that, okay, let's just put a cast or a slab to initially reduce the swelling, and the patient was feeling comfortable, so he left the plaster like that for a month, and then he removed it. But the patient still had pain, and he turned up to us after 5 months. So after 5 months, his X-ray looked something like this. So we can see that there is a small indentation in the distal radius, and this rings a bell that there is something nasty going on inside, which is not visible on a 2D X-ray. So we did a CT scan, and it shows that there was if we see the initial X-ray, there was a lunate fracture which was missed, and this caused arthritis, and the distal row of carpals started going proximally. So there was a proximal migration of the carpals, and also there was a die punch sort of injury. So basically these bones push into the distal radius, and it causes a dent. So that's why it's called a die punch sort of injury. So this was something like a greater arc injury of the carpal bones, and this was a CT scan, and this is a 3D reconstruction of the scan. So we can see the carpal bones have started to jut inside the distal radius and causing a indentation. So no way we could have saved this joint after it has already become arthritic and erosive. So to give patient a painless, stable hand, functional hand, we had to counsel him to get a wrist fusion done, and we also removed all these bones which are already arthritic and used them as a bone graft. So this was the post-operative X-ray of this patient, where nicely we could fill the gap with bone graft and put a plate. So now the patient is able to move his hand properly, hold the things, and ease pain. So thank you. I would like to go on.
Thank you. I will present a case which I have never seen in my whole professional life of 35 years. That's why I wanted to present. This was a 50-year-old male from Africa who presented to me with a history of pain and stiffness in the left hip for the last 6 months. There was no history of trauma or any previous disease like tuberculosis, rheumatoid arthritis, etc. As you can see in this hip, he has got some problem in the left hip which doesn't look similar to the right one, and there are multiple loose bodies that can be seen inside and around the hip joint, with some evidence of osteoarthritis happening in the left hip. We confirmed it with the MRI scan, which showed that he had definitely had multiple loose bodies, as you can see here, all around, and evidence of osteoarthritis in the left hip. The pressure effect of the loose bodies was disrupting the femoral head. So we were faced with a patient who is 50 years old, who has got secondary osteoarthritis happening in the left hip because of a disease which is producing a lot of loose bodies. So for orthopedic surgery, it is not difficult to diagnose. It is Synovial osteochondromatosis is the name of the disease, where the synovium proliferates and metabolizes to form osteochondral bodies. Something like, stones in the kidney or in the bladder, right? So it was like a stony disease of the joint, where we removed more than 100 loose bodies at surgery. When we went in to replace, the head was also, you can see, quite damaged. So this was pre-operative X-ray, this is post-operative after hip replacement. He did quite well, and such cases have not been reported in the literature before. So it's a very rare condition, and we have recently actually sent it for publication. Hopefully it will be accepted. This is the histopathology which confirms that there is diffuse osteocartilage formation from the synovium. So this is an extremely rare disorder. Very few cases have been reported where there is synovial proliferation and metaplasia into cartilage and bone, causing formation of multiple loose bodies. It was like a factory of loose bodies in the hip joint. Lots of loose bodies are present. It is known for recurrence if you just remove the synovium and loose body, but if you do a hip replacement, probably it is unlikely to come back, and rarely it can become a malignant, so you can't leave it alone, because it has been shown previously that chondrosarcoma, it may convert into chondrosarcoma. This is another patient which we saw again not very frequently. Is a 30-year-old male again from Africa who had left shoulder dislocation 1 year ago, and after 2 attempts locally by local doctors, the shoulder could not be reduced back. So he was left with a dislocated shoulder, as you can see here, and that became very stiff. In the last 1 year, it was so painful that he had to take a lot of painkillers, including narcotics and other type of medicines to reduce pain, and he had severe stiffness. His shoulder had become deformed, the normal contour of the shoulder was missing, and he had severe wasting around the shoulder joint. So we did an MRI scan to see what's happening. As you can see, this is the humeral head, and there is a large defect in the posterolateral aspect of the humerus, what we call a Hale-Sat lesion. And this is the glenoid. As you know, glenoid is a very shallow structure compared to the humeral head. That's how we get a lot of movements. And to prevent it dislocating, the nature has given us two stoppers at the end called glenoid labrum, anterior and posterior. It is like a door stopper of a big door. It stops dislocating front, but here you can see the anterior stopper or glenoid labrum had completely disrupted here. So we had a big lesion here. So every time we will dislocate, this will come and engage here. So we had to treat this. So it was a chronic unreduced lock dislocation of the shoulder, which is very, very rare. Considering all the factors, we went in, opened the joint, and found there was a big defect in the head which was not salvageable, so it had to be replaced. So we replaced it with hemiarthroplasty by augmenting the glenoid cavity here. You can see with bone graft and 2 screws. And this chap was doing fine for 10 days, and he was told not to move his shoulder. He was given brace, but maybe because of a language barrier or something, it was hot season. So he tried to put his t-shirt after removing the brace, and he dislocated his shoulder. So he came to us with a dislocated shoulder. So we went in again. And we tried to reduce it under anesthesia, but it was very unstable, so we opened it. So he had completely ruptured subscapularis muscle, which was repaired, and there was nothing left to reduce it back. So since we did not have any other option, we sought the help of a reverse shoulder arthroplasty. This is another very new thing which is coming up, is reverse shoulder arthroplasty, where on the glenoid side, instead of having a cup, you have a ball here. And the cup is on the humeral side. So you reverse the anatomy of the shoulder joint, and it gives very stable reduction. And you can see at 3 months he could abduct the shoulder pain-free, although not fully, because it is a chronic thing, it will take a long time. But somehow we could salvage this unsalvageable condition with the help of a reverse shoulder arthroplasty, which is commonly used for chronic rotator cuff problems, not for these problems. So again, nobody has done this in the literature so far. This seems to be the first case in young person that we have done, and let's hope he gets on well in his life. So neglected locked shoulder dislocations are difficult to treat because of soft tissue contractures and bone loss, and conservative treatment is no treatment for these patients. They always require surgery, and we successfully treated this patient with a reverse shoulder arthroplasty. Again, this was our first experience in last 35 years.
Go ahead, sir. So, Dr. Raju, it was a wonderful talk and a great presentation of those cases, especially the synovial osteochondritis, which is such a rare disease. And you said probably hip arthroplasty is the treatment modality of choice. So when you do a hip arthroplasty, do you go through an anterior, posterior or a lateral approach?
You can go by whichever approach is more conversant with you. I do most of my hip through direct lateral approach.
Lateral approach. Wonderful. So, little word about the robotics. Is there an option for this here in hip replacement?
Robotics have recently been used in hip and knee arthroplasty. They are quite useful in complex cases, but since this was not a complex case for doing joint replacement, he had a complex pathology though, there is really no great need for using robot. And we unfortunately don't have a robot at the moment to use.
Okay, so Dr. Raju, when you do a TKA, so the argument whether the knee ligament is need to be preserved or not is still being talked about today. And aren't there recently any concerns? I think there are no concerns in the long term. But if you preserve the knee ligaments, probably the gait would be better. What do you say?
I think you mean by knee ligaments, PCL. We sacrifice anterior cruciate ligament in all types of knee replacements, except for unicompartmental knee replacement. We always preserve medial and lateral collateral ligament. So the only ligament that is controversial is PCL. There are two types of prosthesis. One is PCL sacrificing, one is PCL retaining, preserving. In most of the cases in India, when patients get ready for knee transplant, already have severe deformities where there is severe contracture, varus deformity, contracture of PCL. So in most cases, 90% of the cases, you have to sacrifice the PCL and use a PCL sacrificing prosthesis. Whereas patients with minor deformity, good ligaments, you can preserve PCL, you use PCL preserving knee, or also known as cruciate retaining knee.
My last question, Dr. Raju. A lot of my patients come to you for knee replacements, especially SARS, if you remember. Okay, so conventional TKA versus missed TKA. So BMI more than probably 40, fixed severe valgus deformities, severe osteoarthritis, rheumatoid arthritis, and previous arthroplasty, probably we go for a conventional TKA?
Yes. Minimally invasive surgery is good for lean and thin patients with mild to moderate deformities, not for severe deformities, certainly not for morbidly obese with greater than 40 BMI. So I'll go for conventional because doing a good surgery is better than going with the fashion and do something hodgepodge.
Thank you, thank you.
Sir, after a very nice talk, sir, I was impressed by Dr. Wadhwa's comments that you had published so many papers in COVID initial stages. So were your papers based on COVID effect on bones and joints or something else?
50% were related to impact of COVID on orthopedics and otherwise, but more than 50% were actually on other things. Like we did a lot of papers on based on the statistics of Apollo group of hospitals. How did COVID impact on the inflow of patients? How COVID affected the outcome of patients in various specialty and so many things.
So
I became a non-orthopedic surgeon.
I'm reminded of very early days of COVID breakout when me and Dr. Tulsi used to have a tapsara. से आजकल के हालात पे तबसरा तो we used to say and inform our gathering what is coming in the pipeline, what is next to come, breath analysis test for we talked about 2 years back. Anyway, sir, my next question is that synovial chondromatosis, why it is unilateral? Is it because it's a systemic thing?
It's a disease of the synovium basically, and it can be polyarticular but very rare. Mostly it is monoarticular, that is the characteristic feature of it. Like cancer, why doesn't it happen in both lower limbs? Unfortunately, it happens only in one side.
My small question to the young chap, our Abhishek कर देते हैं सवाल से. Sir, cytokine storm you said in your patient. So we are so much fantasized by cytokine storm in COVID. So it's a gush of inflammatory cytokines. So in our cases of COVID and all, we use steroids also in cytokine storms. or some other anti-inflammatory stronger medicine. Are you using such medicines in your cytokine storm to poison it, or it is just a passerby?
So sir, as far as surgery is concerned, we are concerned about the time of surgery, as we say cytokine storm. We have physicians managing all the other things, but for surgery concerned, we either operate the patient initially when the injury has happened within a few days, or after a few weeks when all the things have settled down. But we don't like to do steroids initially for the patient as the injury is already there.
Can I just add one more thing? Steroids were great, in COVID times. They saved many lives. But bad effects of steroid use in patients who have survived have now become to resurface. And especially in orthopedics, what we call pandemic after pandemic. One pandemic is over, now we are facing a pandemic of hip disease. No, not osteoporosis, osteonecrosis, avascular necrosis of the femoral head. Previously, I may be seeing 5 cases in a year related to steroid use alcohol. Now I see at least 5 cases in a month. That common in young patients, because COVID itself is a hypercoagulable state, and if you have steroid rampant use, steroid also causes hypercoagulability. Both together causes severe damage to the head. So we are seeing a pandemic after
basically avascular necrosis of femoral head.
Yeah.
That's very important. And so first my congratulations to Abhishek, and then you said posterior cruciate ligament sparing. Is it common in unique compartment replacement of knee, or is it more in high flex knee, something related to the procedure?
Right. In unicompartmental knee, where you resurface only one compartment of the knee, that is femur and tibia. You don't do anything to the patella, and you preserve all ligaments. You don't sacrifice ACL, PCL, MCL, or LCL. Whereas in total knee replacement, you have 2 options. You either sacrifice PCL or you preserve PCL. But in Indian patients, 90% of the time you have to sacrifice the PCL because that is severely contracted. Right?
When you do unicompartment, is it medial compartment mostly?
Medial compartment osteoarthritis is 95%, and lateral compartment osteoarthritis is only 5%.
So mostly medial compartment when you do unilateral. Thank you.
Sir, some wonderful cases by Abhishek and by yourself. Being a physician, my concern is at times we have, as some of the questions have come up, that there is only unilateral arthritis, the other limb is fine. And some of these patients, if you go into the history, they will tell you, हाँ 20 साल पहले इस वाले पैर में एक्सीडेंट हुआ था, मैं गिर गया था. But you have to, really prod them into it. So this is secondary osteoarthritis.
This was secondary osteoarthritis.
This was secondary osteoarthritis. Sir, I want to ask you, between primary and secondary osteoarthritis in TKR, which one has better results?
You see, primary osteoarthritis certainly has better result because secondary osteoarthritis happen after secondary to some pre-existing disease or trauma. So the effect of that trauma may cause, for example, malalignment, intra-articular or extra-articular contracture of soft tissue, stiffness already. Whereas in primary osteoarthritis, your knee is virgin, and that will give you better result because other things are normal. So I would say primary osteoarthritis gives better result than secondary osteoarthritis.
So my second question is, many of our patients are documented seropositive rheumatoid. And we know that rheumatoid does not affect all the joints uniformly. Some of our patients unfortunately have very severely affected knee joints. Once you replace these knee joints and you do bilateral TKR, what does the rheumatoid process do to the replaced knees?
Right. Again, rheumatoid arthritis per se is a synovial disease. Right? It affects the synovium, and then once the synovium is hypertrophied, it produces different types of chemicals in the joint which destroy the joint, and it covers the articular cartilage and damages it by venous operation. Once you remove that and replace it with the artificial joint, even if you have synovitis, it cannot kill the cartilage because there is no cartilage, it is replaced by bone. So nothing happens to these joints. And usually, if synovium doesn't get anything to eat like cartilage, it dies down. So you don't have any inflammatory changes in that particular joint.
Sir, you mentioned that just when we started asking questions that when we do a TAKR, 90% of the times you sacrifice the ACL.
ACL is 100%.
ACL is 100% sacrificed.
You cannot do a knee replacement totally
without sacrificing them. Sir,
because you have to remove the upper end of the tibia and distal femur where the ACL is attached, whereas PCL is attached in the back of the tibia.
Sir, but these are important ligaments. So what performs the function of these ligaments once you have done the TKR?
Yeah, good question. Suppose this is a femoral component, artificial, there is a box. There is a box, right, as a channel. And on the tibial side, there is a plastic which has a spine. That spine goes into that box, cam and post. And it works like a normal.
So what is the life of a normal knee replace prosthesis? Many want to ask this question.
Well done knee replacement should last with the modern prosthesis for 25 to 30 years or even more.
Wonderful. Sir, just a minute, sir. Sir, is there a difference in the performance of TKR in people who have severe osteopenia, osteoporosis versus those who do not have these? Or if I ask you bluntly, sir, between male and females, because most of the females by the time they require a TKR, they would be severely osteopenic.
Right. Dr. Chauhan, as you know, osteopenia and osteoporosis are disease of bone, not of the joint, right? And in osteoarthritis, which is a disease of the joint, there is, instead of osteopenia and osteoporosis, there is osteosclerosis. The bone becomes hard. So there is no problem in doing knee replacement in those cases. You get osteoporosis only in patients who have inflammatory disease like tuberculosis, like after rheumatoid arthritis and so on. But 90% of our cases are osteoarthritis. So there is no effect of osteoporosis per se on joint replacement.
Sir, diagnosed at the age of 30 years, a young female with osteoarthritis, when she comes to me, my first response is, "Aap exercise karo, physiotherapy karo." How much time do we give her before she gets to you for TKR? Done properly, done optimally, done honestly.
First of all, I would be very serious about a patient. I would be very serious and concerned about a patient who is only 30 years old and present to you with osteoarthritis.
Sir, this happens, sir.
Yeah. This happens only in one condition, which is known as primary generalized osteoarthritis, PGOA, where there is severe inflammation. It behaves like rheumatoid arthritis, but it is not rheumatoid.
Seronegative.
Seronegative. And it happens in patients, and in these patients, usually the peripheral joints are also involved, which is rare in otherwise primary osteoarthritis, and this is genetic condition. Usually the parents would have this, so it runs in family.
How much time does she have before she gets on the table in Apollo in front of you?
We have to
with the optimum treatment.
We have to consider both clinical aspect of the patient as well as radiological aspect. Patient should be symptomatic enough to require surgery. She has to take painkillers every day. She can't sleep. Arthritis is affecting daily activities of living, and she has tried good conservative treatment, physiotherapy, etc. But still, and the joints have become to deform.
So this is a real life case, and I will not name the orthopedic surgeon. She went to an orthopedic surgeon who advised her intra-articular injections of steroid. Is that a good alternative, good option or not?
Intra-articular steroid injections are wonderful in patients who have inflammatory component. If they have effusion and synovitis, nothing better than intra-articular steroid injections, but they should not be repeated frequently. I often say that first injection works for 6 months, second injection for 6 weeks, and third injection only for 6 days.
Wonderful.
Dr. Kapoor has a question.
A small question.
We have a question from our orthopedic friend.
Which is a better, PRP or eyelid cartilage injections?
See, theoretically PRP is better because you inject platelets which are separated from patient's own blood and they have regenerative potential. But some people call PRP as also a good placebo, right? Similarly, hyaluronic acid is also, some people call it placebo, but these things are good if patients have mild to moderate osteoarthritis, not severe osteoarthritis.
And what is the result of the cartilage transplant which are you are doing?
Cartilage transplant is very good for young people who have focal cartilage defect, mostly after injury or osteochondritis dissecans, not for osteoarthritis, which is a global disease of the other.
A small question. Is patella a disposable bone? So you can do patellectomy in committed fracture of patella or something. Is it a disposable bone?
It's an accessory bone. It is not disposable bone.
It's an appendix.
No, it has an important function. When God has given something, it has to have some meaning. It is very useful for especially stair climbing, coming down and out. So those who have patelectomy because of severe injury, etc., may find it difficult to climb stairs and they have weak quadriceps.
I request Dr. Wadhwa